Oh, okay, I was waiting for you. All right, okay. No, it's all right. All right, time to get going. Um, I got to say, if you look at the slide, look at the very top little line there, ninth annual. This is the ninth year that Tim Siegel's been putting this on, and Rhonda. And this is really just so amazing. Every year, I say the same thing, a broken record, but this is, for my wife and I, Juliet and I, this is one of the most fulfilling things that we participate in every year. And the impact of this, I think, is inestimable in terms of being able to reach people. That's part of what this talk is about. You'll see at the very end is that, this therapy has been around for 363 years now. And why aren't we using it? And there's a very ugly story behind that that's going to come out very publicly this year and early next year. But we're finally to the point where this is reaching awareness to a larger group of people. And that's what we're here for. So, every year Rhonda asks me for a title. What do you want to talk about? And I give her the title, and sometimes they're kind of specific. Like one year it was about drowning. And she said, no, this is acquired brain injury. And I said, she said, make it, more generic. And so what I want to do, it just dawned on me. I don't think any of these years we've really defined what is acquired brain injury. That's the title of this conference, really. And what I wanted to do was look at cerebral palsy as kind of the template and example of acquired brain injury. So here's the Team Luke mission, if you will, and the story, and what this is all about. It's about providing resources and information for people, families who have children with acquired brain injury. And that begs the question, what is acquired brain injury? And it turns out that it is injury or damage to the brain that occurs after birth. Now that kind of gets a little technical, because when does the birth moment start? In the birth canal or when you're finally out? But many of the injuries surrounding birth are occurring right at the time of delivery. But there are a variety of causes. You can have traumatic brain injury, you can have stroke, and then non-traumatic brain injury, which includes a very wide range of different diseases. And it can affect people of all ages, all severities, and the symptoms can include physical symptoms, cognitive symptoms, emotional ones, sensory problems. And I think many of you know, most of the children have almost all of those involved. If we look at examples, traumatic brain injury, this can happen in a variety of ways. Simple concussion from a fall, sports injuries, abusive head trauma, shaken baby. I think I've shown a case of shaken baby that we have treated. I think I have 11 or 12 now that, over the 40 years that we have treated. Assaults, motor vehicle accidents, sports injuries, gunshot wounds, penetrating type. And then this thing called diffuse axonal injury, where when the brain is severely traumatized, the most fragile part of the brain are the connecting tracts, the white matter. So the outer part of our brain is gray matter, where most of the cells are, and at the deep center. And then it's all connected by a cable system, which is very fatty. 63% of it is fat. And it's extremely fragile. It's just like the cable that brings signal to your house. Those fiber optic glass cable, they're very, very fragile. So when this brain is shaken, those cables are damaged. And that's where a lot of the injury occurs in acquired brain injury. And then, of course, the non-traumatic ones, we have vascular events, stroke, aneurysm ruptures, heart can stop, and that's essentially a vascular injury to the brain. Near drowning is a perfect example of that. Hanging, suffocation, choking, even carbon monoxide poisoning. And then we have infections, meningitis, which is the covering of the brain, encephalitis, which is the brain itself. Tumors of all types can cause injury and damage. And then the treatment of them. Radiation is a very, very common injury to the brain in treatment of cancers. And then we have toxic and metabolic ones. So drugs and alcohol exact a toll on the brain, just like the rest of the body. And probably the greatest toll, smokers, for instance, pack a day average for life your lifespan's shortened by 15%, which means we used to be average age span about 80. You're checking out at 68. The last 5 years of your life, it is just medical problems and complications. Your body falls apart. Trauma or stroke, lung disease, cancers of all type and such. But alcohol and tobacco take a toll on the brain. And of course, we can have liver and kidney disease when your vital organs go bad. They affect the brain. Insulin shock, neurological, epilepsy, a lot of things can do this. And then we have hydrocephalus, where the fluid system in the brain gets blocked. Fluid keeps producing, it expands, compresses the brain, and people have decided it's water on the brain. And this is fairly common after, for instance, brain bleeds, because the blood can block the fluid system in the brain, and people have to put a shunt in. Neurodegenerative conditions, and we got all sorts of those. The most common one, late in life. But it's these insults earlier in life that cause the degenerative diseases later. So I don't know if you're aware, but Alzheimer's now, they've identified 36 different causes of Alzheimer's. It's many of the things that I put up there. Okay, so what determines whether a person with an acquired brain injury has any of those types of problems? It's the area of the brain that's injured. How's the brain organized? We've got all of these different areas that are responsible for different functions. And this has been mapped in a gross way. Now, each of those colored areas, there are, 10 to 20 billion brain cells in there, and approximately 100 billion support cells. But you can see the frontal lobes involved with planning. That purple is the motor strip. The yellow is the sensory strip, controlling sensation. The very back in the blue, that's where vision is. Although just that area is the actual vision. Visual images are stored over 40% of the brain's surface. And then the temporal lobes involved with memory, emotion, behavior, and so on. So what determines with your acquired brain injury what kind of symptoms you have in deficits is purely the areas of the brain that are involved with the injury. And treatment then, of course, depends partly on the severity, on the cause of it. But in fact, you're going to see that many of these therapies that you're introduced to at this conference are generic, meaning they act in basic common ways on the underlying disease processes and the injury itself, such that they can apply to many, many different diseases. Well, how do you treat acquired brain injury? One of the ways is with hyperbaric oxygen therapy, which I serendipitously happened onto 40 years ago. And of course, we have to ask the question like we did with what is acquired brain injury is, what is hyperbaric oxygen? This was theorized and first proposed in 1662, but I'm going to tell you this therapy has not been understood scientifically until 2008. And 2010. And this has been the problem with this and why it has not expanded, because doctors have not understood it and they haven't been able to define it and explain it to other doctors. And if doctors don't understand something, they will not refer a patient for it. And we could go into the detail of it, but the way this got defined was by a little group of doctors in 1978. Chambers came in the United States in 1960, got introduced, 59, 60, and by 78, the FDA was like, well, wait a minute, what's going on here? We got all these hyperbaric chambers. The Medical Devices Act got passed in 76. Now, all devices and drugs in the United States had to go through an approval process with the FDA. But everything that had been there before got grandfathered in and approved. And they went to the hyperbaric experts and said, well, what's this good for? And the doctors gave them this list of diagnoses. And they said hyperbaric oxygen is defined as the treatment of these diagnoses. Now, I'm just going to tell you, we can go over the details of it, but that is the most unscientific, dopey definition. And it's guided this field, misguided this field, for now 65 years. They actually did that before 78. In fact, what we're doing is we are using increased oxygen and pressure as drugs to treat the underlying disease processes that cause diseases. And those underlying processes are common to many, many diseases, which is why this has such widespread, almost generic application. So it's a treatment for disease pathophysiology. This is a list of all of the diseases that hyperbaric oxygen has been applied to over the years, 132. And this comes from an article in '87 where it was highly critical of hyperbaric oxygen. They said, look at this. Look at all these things they treat. Explain it. Nobody could. Here's some more of them. But if you look at all of these, they are wounding conditions of various types and inflammatory conditions. And it turns out those two categories cover a very, very wide range of human disease. In fact, if you look at 8 of the top 10 causes of death in the United States, inflammation is a dominant part of the physiology. And this is a very powerful anti-inflammatory treatment. Well, it turns out all living organisms, and we can argue this a couple of different ways, are sensitive to changes in pressure and oxygen. Do you believe in creation? I do. God made us this way. But if you want to argue the scientific angle and evolution, where did we come from? We came out of the oceans, right? Which means that if you lived in the ocean underwater, you have to be sensitive to that pressure. And similarly, at altitude, birds, us climbing to altitude, you've got to be able to adapt to changes in altitude. Everybody knows that. Go live in the Rockies or go train for athletics. What do? Train high, compete low. You go and you train in the mountains, and what does your body do? Genes are activated, and what ends up happening is you make more blood. That's also what blood doping is about. And so we are all sensitive to changes in pressure and oxygen. And this was not appreciated in the field of hyperbaric medicine, except in the treatment of divers. So you go diving, you go underwater, you're breathing air at greater pressure. What happens? All of that air, oxygen and nitrogen, is dissolved in our tissues. Now when you come back up, the oxygen's not a big deal, but the nitrogen is. You have to get rid of it. If you come up too fast or you stayed down too long and didn't make stops on the way up, bubbles form in your body and in your bloodstream. That is diver's disease, Caisson's disease, decompression sickness. Well, you go in a chamber, and what does the pressure do now? You go back under pressure, it compresses the bubbles, puts them back in solution, give people oxygen, exchange for the bubbles, voila, you're treated. But the hyperbaric medicine field, and nobody realized that pressure, increased pressure or decreased pressure, also has effect on liquids and solids, our entire body. And we didn't know this until 2008, actually 2010, excuse me. I applied to the Food and Drug Administration to get a special type of exemption. It's called an investigational new drug exemption to do the study we did on traumatic brain injury. And for the first time, hyperbaric medicine got moved from the devices side, hyperbaric chamber, of the FDA to the drug side because 100% oxygen is a prescription medical gas. It's a drug. So the drug people, they said, well, wait a minute, it's a drug. We should have it over here. So for the first time in the history of hyperbaric medicine in the United States, the FDA, my IND went into the drug side. And now these doctors taking a fresh look, first time at hyperbaric medicine, it's like, wait a minute, doctor, you got two things going on here. You got increased pressure and you got increased oxygen. And you're asking us to approve your study to treat one dose of pressure and oxygen. No. You've got to do a whole bunch of different pressures and oxygen levels. I said, you guys are crazy. I've been in this field all this time. Nobody's talked about pressure, and what are you talking about? So, and I always say, when the going gets tough, go to the library. I went to the library, and what did I find? 1999. That is a summary of 50 years of elegant physiology showing that all living organisms are sensitive to pressure and oxygen. And what's the problem? These are all studies done by PhDs. The MDs don't talk to the PhDs, and the PhDs don't talk to the MDs. So here's all this literature, and nobody in clinical hyperbaric medicine had ever bothered reading this stuff. And so now it was a whole new world. And so just as I was mentioning earlier, all you got to do is look. We've got birds that live and thrive at different altitudes. We've got crops and cattle, livestock, different livestock that thrive at different altitudes. This is from the Andes, showing that certain species and so on do better at certain levels, and now going in the ocean. Turns out that all of the plant life is stratified by depth. which means they're living under different pressures. They are sensitive and adapted to that pressure. And similarly, all the animal life in the ocean. I don't know if you ever saw the Titanic discovery and the ROV they sent down with the camera, and the sea life at that level. It's not found anyplace else. But, it's adapted to 10,000 feet of water pressure. And what is pressure? Well, right now we are at, I don't know, Austin, what is it, 500 feet elevation or something like that. We're a little bit above sea level, but let's take sea level, where I live in well, we're a little underwater, actually. But sea level pressure is 1 atmosphere absolute. What is that? That's the weight of air from where I'm standing to 100,000 feet, or 100 kilometers, into the atmosphere. That's the weight of air. That is 1 atmosphere of pressure. You only have to go 33 feet underwater to get the same amount of pressure, another additional atmosphere. So water pressure you can do with just a very little bit of water, but air pressure, you have to compress it. And I look at this like a balloon. You inflate a balloon, you've got increased pressure in that balloon. You put your fingers together, that is mechanical, but also pressure that you're exerting on tissues. And it turns out all of our tissues are sensitive to changes in that. But the only way you can deliver this to the whole body is you've got to put the whole body in a chamber. So a sealed container, and then you force more air in and oxygen, and you increase the pressure. And this is a little newborn that I treated many years ago, and now we're seeing more and more children that we're treating early, and the effects are profound. Rather than waiting for the injury to mature and get years out where you now have a stable, unchanging brain and have lost a lot of brain tissue. So what I want to do was now focus on cerebral palsy as kind of the model for acquired brain injury. And what is CP? A number of your children probably have been given this along with HIE, or, the two, really, which one your child gets a diagnosis for somewhat depends on the neurologist that's treating him. Because this is a descriptive diagnosis that appears in infancy or early childhood and permanently affects body movement and muscle coordination. So it's defined by the motor deficit. So if you have primarily a motor problem, you can end up with a diagnosis of CP, but it doesn't tell you anything else about it, where the lesion is, what the cause was. It turns out it is thought, they like to say that many of these occur before birth, but in fact, the majority of them are occurring at the time of birth or shortly thereafter, especially in premature babies. And the symptoms, it turns out, are caused by problems as the brain is either developing or from the injury at that time. But a lot of the injury is to the brain's white matter, and I'm going to show you that in a minute. It can also happen by interruption of brain growth from gene changes caused by low oxygen and low blood flow, of direct bleeding in the brain, or an overall lack of oxygen. And it turns out that is the leading cause of childhood disabilities. Prematurity, what happens with prematurity? The last area to develop is at the center of the brain. And so when children are born prematurely, that area is undeveloped and very fragile, such that the children are susceptible to spontaneous bleeds in that white matter. And that leads to the term of leukomalacia, white loss, or loss of white matter tissue. And this is a very common thing. Well, what are those white matter tracts? Most of them, or a good number of them, where it gets centered is motor control. But what they are wounds in the brain. And as I talked about earlier, what is hyperbaric oxygen? For all these years, it's been a treatment for wounding and inflammatory conditions. And so if we look, there is the motor cortex, the red area. We're looking at the brain from the side, and it runs right across the top, kind of in a semicircle there. Right behind it is the sensory cortex. That yellow area in the front is our speech motor area. Many of the children who don't have speech, it's damage to this area in the motor tracts that are involved with that. If we look at the brain indifferent, not from the side, but looking face on and take a slice right through the motor tracts, you see the blue all along the top there. Oh, I got a laser pointer. All of this are the motor tracts, and they send their processes down, And they actually make a stop here and then continue down through the brainstem to the spinal cord. So interruption of this anywhere along here can give you cerebral palsy. It's like disconnecting the electrical cord. And here's a picture of it with special type of MRI, where there's been injury up primarily in this left-hand side, and you can see the thickness of the white matter tracts, much less here. And with that loss of thickness, what happens? The ventricle, the fluid system enlarges, because the wall of it are the white matter tracts. And here are just pictures, different ones of how this is. You can see a big area of tissue loss here. Here's an acute one with a fresh injury, another one with dilated ventricles. A big area that's involved. This was a whole artery that turned out to be injured. Here's the back of the brain, the whole area, that white is injured. Another big area that's been lost from bleeding on this side. Here is injury up in the white matter tracts, both in the front and the back of the brain. And the net result is, and this has been classified in different ways, hemiplegia is when you've got injury to one side of the brain. Diplegia, the two lower extremities, is injury on both sides right at the top. Quadriplegia, all four extremities not working and paralyzed, is damage to most of the motor system. And then the athetoid one, where patients can have funny type of uncontrollable movements, writhing movements, and dystonic ones, as well as ataxia, are actually down here in that deep gray center where those tracts make that short stop on their way down to the spinal cord. So it turns out they've classified this into different types: the spastic with increased tone, damaging those motor tracts in the white matter; extrapyramidal, which is the other ones I showed you that are down in the deep gray portion of the brain, the basal ganglia. You'll probably hear that term, thalamus, cerebellum. And then mixed one that's involving injury to both areas. Okay, so now we got to do a little science. And hang with me here, because you're going to know more than your doctors do now about this. And it's going to be helpful because you want to be able to discuss this with your doctors and about why your child needs hyperbaric oxygen and other therapies. Years ago in Canada, they developed a measuring tool called the gross motor function measure to measure the motor disability or deficit in children with cerebral palsy. And it has 5 dimensions: lying and rolling, sitting, crawling and kneeling, standing, and then walking, running, and jumping. So essentially ascending level of function. And what they've done is they have been able to break this down into severity to different classification systems, which are these 5 different levels. Here's the GMFM score. So you can see the ones that are level 5 here have, as they go through life, have a very low level of function. And the level 1s are the ones with mild form of injury. They will improve in function as they age, but eventually they come to a plateau as well. Problem is, the more severe you are, you come to a plateau much earlier. And then what I didn't show here is that all of these curves drop off, particularly the lower ones, meaning after mid-teen years, really it starts at about 8 years of age, motor function begins to decline in children with these types of injuries. Well, what's the problem with these curves? Well, there's a lot of space between them. And so it's kind of crude. Describing a level here, it can include, a wide range of children with GMFM scores. And there's quite a bit of variation. Another problem with the use of this is that many studies that are done on children with cerebral palsy, where they're trying to look at the effectiveness of a type of therapy, don't have a control group. They just do the therapy on the children. And there's no way to compare to what is the natural improvement on those curves. At least you can kind of grossly, but in any given study, you can't. And it's led to problems because people do a therapy and they say, oh, look, we got some improvement. But let's say they did the study over 10 months' time of therapy, they made that much improvement. Well, if you did another therapy and you made the same amount of improvement in 2 months, you've got a better therapy there that did it in 2 months. But these aren't compared that way. And so what happened is that doctor, Saint Dr. Pierre Marois, is a physical medicine and rehabilitation pediatric specialist in Quebec, Canada. And he was following his normal children that have CP and so on in clinic. And two twins went to England and got hyperbaric therapy after we had shown this first case I'm going to tell you about in 1992. And they came back from England, and these kids were improved. And he looked at this and said, what is going on? One thing led to the next. More children saw it. He visualized it. And they started applying for money to do some studies on cerebral palsy. But what he also did as he got farther along, because the studies, you're going to see them, show this really dramatic improvement in children with CP, we couldn't get the medical profession to buy this, even with imaging that we showed, with everything. And so what happened was he decided to take all of these published GM-FM 66 scores that the Canadian government, they tracked children through their health system over time. And they took 657 children, and they found an equation. Now, I want you to remember that, because a little later we're going to have a quiz on this. They were able to now accurately predict if you had a GM-FM score for a group of children, let's say 29.6, they could put that on a curve, and with that equation, now predict exactly where that group of children would be, the average, a year out, 2 years out, 4 years out. And it now gave precision to this, but what it also did was these curves were based on children that had standard physical therapy once a week. And so that was considered the natural improvement rate. And what they could do now is compare the natural improvement rate to the improvement rate done in any study. And what they found is, if you look at these, this is the expected natural evolution over 1 month. And this is the rate of improvement in the GFM. So you can see that the real severe ones, by the time they're out here, 4 to 8 years, they are changing very, very little, almost none. So that any therapy done out there should be able to see a change and be easily measurable and comparable. But if you're back here, take a look at this. These colors here, you're having rapid improvement. Well, that occurs earlier on, and actually the lesser the injury, the more of those children are going to be on that rapid improvement rate. And it kind of makes sense. More damage you have, more injury, the more loss of tissue, you're not going to do as well as someone with a lesser amount of loss. Well, what it allowed them to do now is you could take those curves. Let's say you're going to do a study and you evaluate hyperbaric oxygen therapy. Take a group of children with cerebral palsy, and you get their GM-FM, you measure it on all of them, get an average score, that puts it on the curve. And you now know you can go look, the study's going to go 8 weeks long, you can go 8 weeks out and look exactly where they're going to be, that natural rate of improvement. Now you do your study and you measure where they are, what their GM-FM is after those 8 weeks. And now you got a different point on the curve and you can compare them. So what he did, this is all published and irrefutable. Well, what happened? CP, unbeknownst to all of us, in Brazil, 1983 to 1989, 6 years, there was a Dr. Machado who treated 230 children with cerebral palsy, and nobody knew about it. It was in a little symposium, but it finally got presented in 1990, I believe it was, in a conference in South Florida, and still everybody ignored it. And what they had done was hyperbaric oxygen for these children. And he reported these phenomenal results. The children who had seizures had a marked reduction or cessation of seizures. Again, it was ignored. I didn't know about this. We were doing a study starting with boxers and divers, trying to see if this improved their neurological function. And it did. And next thing you know, we opened it up. And the first case got referred. And I got to tell you, I've got to honor Dr. Sheldon Gottlieb, and I'm very conscious of giving people credit for what is due to them. Dr. Gottlieb was our director of research. We had a nonprofit, my senior partner did, along with the clinical hyperbarics we were doing, the wound care and all of that. And Dr. Gottlieb was in charge of it. And here we were now seeing these improvements in divers, boxers, people getting referred with traumatic brain injury, with stroke, etc. He was professor of biology at University of South Alabama in Mobile, Alabama. And one evening he goes to a cerebral palsy support group meeting, all these mothers, and he stands up at the end of the meeting and goes, "We got a treatment for your children. We can treat your kids." And the next day he calls me up and he goes, "You're going to be getting a phone call from some parents of children with cerebral palsy to treat in your program." And I had a fit. I said, "Shelley, what do you know about CP?" He goes, "Nothing." I said, "What do I know?" I had one child in pediatrics, my pediatric rotation in medical school. I said, "I don't know anything about this." I said, "Are you crazy? You promised these mothers?" And then I stopped cold. I said, "Wait a minute, how did we get on this?" It's by being open-minded. A wound is a wound. What's the difference between a diabetic foot wound we were treating in our wound care center, radiation wounds that we were treating, a stroke, a trauma, an internal wound? There was no difference. We treated this child, and he just had a remarkable improvement. He was 4.5 years old at the time. He had a significant birth injury, and at 4.5 was a floppy little kid, just kind of sat in a pile, slumped over, drooling, couldn't eat, no speech, had no tone, no motor function. And at the end of 2 courses of hyperbaric treatment, progressively, he was walking with fingertip support for balance. And we were beside ourselves. It's like, my God, look what happened here. And literally that changed my life. That and the patients before it. Well, what's happened is after that, it got out. We showed it at meetings. The studies were done. The Canadians did a bunch of work on this. And finally, there were a whole bunch of studies that got done. And the Canadian government and a study done in Ohio or Indiana, they made a mistake. They took a control group where they gave them pressurized air compared to the pressurized oxygen group. And lo and behold, the 2 groups did equally well. And of course, nobody knew how to explain it, so it got called a placebo because the air was thought to have no effect. And of course, the oxygen, if the 2 ended up with the same result, it had to be a placebo effect that was causing all of these children to get better. And there was all sorts of argument about this. But what ended up happening is Dr. Merwa started looking at all of these studies, and he started looking at the GMFM measurement that was done in these studies. And he started talking about it at meetings. And in 2023, I begged him to put this in a journal article. Well, I'd been invited to guest edit in Frontiers in Neurology, a special topic on hyperbaric oxygen. And so I'd invited all of these doctors to submit articles. They're all peer-reviewed and so on. And his was the number one that I wanted done. And here's what he did. Here are the studies and the common therapies that are done in cerebral palsy. We have normal PT, less than 2 hours a week. That's what all those curves, the expected natural evolution, are based on. Intensive PT, which is 2 to 5 hours a week, then very intensive, which is more than 5 hours a week of PT. Dorsal rhizotomy, you know what this is? That is cutting the dorsal part of the spinal cord. Surgery, they go in and they divide those tracts, the sensory input, which are responsible for transmitting the message that gives the rigidity, the high tone. It's a permanent type of injury. Stem cells. Hippotherapy, believe it or not, horseback riding. It's physical therapy on horse that they do with the children, and it's very effective. Botox and hyperbarics. 48 studies, 44 for all the therapies compared to 4 of the hyperbaric ones. And they calculated this gross motor functional measure evolution ratio, which is a comparison of the natural occurrence to the what was done with the therapy. And here are the studies. I want you to memorize all of these. As you can see, here's common PT. I just want to show you the numbers of them. Intensive PT, very intensive PT, selective dorsal rhizotomy, cutting the spinal cord, a lot of therapy. Look at all these studies. Wow, poor kids. Botox plus PT, 2 horseback riding studies, bunch of stem cell ones, and the hyperbaric ones. And there's the results. So this is the improvement in GMFM over the equivalent amount of time. Common PT, intensive PT, very intensive. Cutting the spinal cord is just a little bit better than intensive PT. Botox, horseback riding was the next most effective. Stem cells, which, kind of was around the average of the others. And here was hyperbaric oxygen, hyperbaric air. And here was one of those clever studies they did where they put the children under pressure, but then gave them a low oxygen blend that at pressure was the amount of oxygen we're breathing in room air. So it was a study of pure pressure alone. And look what happened. Pressure alone had the same effect, almost a very intensive PT, but you needed a little more oxygen to do the trick. So if you take the numbers here, what this boils down to is, there they are. The average of all of these other standard therapies, 6.9. And here were the hyperbaric ones. That was the faux hyperbaric, just pressure. But essentially, this was over 4 times as effective as the average of all of the other therapies. Hard science. And what is the importance of that? How do things get reimbursed? They're based on randomized trials, generally, where you do a study and use a computer to arbitrarily divide the children into 2 groups. One that gets the therapy and the one that gets standard of care or nothing, as a control group. As it turns out, if you can show insurance companies, this is a really complicated, almost corrupt matter, the way hyperbaric medicine is reimbursed in the United States. And we are working on that right now at a very high level. But suffice it to say, cerebral palsy and all of these childhood neurological injuries are not on the Medicaid or Medicare list. However, how is the Medicaid law worded? It's for therapies that are medically necessary or to correct or ameliorate a condition. And based on that, Lyndon Baines Johnson, President Johnson, wanted that in there because he wanted children to be able to get therapies for their condition and not have to wait for the decades of medical research to prove it. If there's some evidence that it does work, he wanted it to be able to be delivered to children. So what ended up happening, a doctor or a father in Georgia, David Friels, got hyperbaric oxygen for his very severe CP son. And he improved. Again, I'll use that word dramatically. It was just stunning what happened with this child. And he tried to get it reimbursed by Medicaid, took Georgia Medicaid to court and won. There are now 23 more states that we know of, this was by 2005 roughly, that have taken taken their state Medicaids and gotten them to pay for this based on this statute and the law. Right now, we're working at the federal level to do this as well. But for insurance, you can do the same thing. Apply, it'll get rejected, and then on appeal, you put this evidence in front of them. This is so powerful. There is no way to refute what is there. And it's available to everybody. It's a free download. And now I want to show you a couple things to end this with. Okay, we're going to test my escape. And I want to start by showing you what's possible with hyperbaric oxygen. This is the story of a little girl that I treated just this last year. Oh, how do we get this? There we go. Playing with her sister at her uncle's house, Labrador nipped in her face and took off part of her nose. Luckily, they thought to look for her nose on the floor. Luckily, they found it, put it in a glass
expand their blood flow. Lucy's mother, Dr. Jen Earl, a rheumatologist in Baton Rouge, asked physician colleagues for advice. Many said there was nothing. Lucy would need months, maybe years of reconstruction from a forehead scan later on. But a friend mentioned the hyperbaric oxygen chamber. Time was of the essence. The Harch Hyperbarics in memory. Grafted tissue healed up within 20 minutes of hyperbarics. We became very hopeful and we could see it was getting blood flow. Lucy went into the tank daily for months, sometimes twice a day. And every 3 hours at home, Dr. Earl used a home oxygen concentrator. The hyperbaric treatment then not only oxygenates it, we're drawing the blood vessels into the tissue. And that's what takes time. This is unprecedented. This has never been achieved. Undeniable evidence. Look what just happened recently. Little befriending family dog and bit the end of her nose off. This is 100% failure. You put the nose back together, put the piece on just to buy time as a biological dressing until you can do 3 reconstructive surgeries. And what happened? Started failing. By 8 hours, by 32 hours, it was deep purple. And by 40 hours, even worse. And yet, with one hyperbaric treatment and a video, picture tape, just 20 minutes after the one showing me, here it is in the chamber. And with daily treatment supplemented with oxygen at night at home by her mother, there's 100% salvage of this, such that her nose looks pretty good. Dr. Harch is using hyperbarics to heal people who've gone through other types of surgery, medical or cosmetic surgery, like facelift. He's found that it dramatically reduces inflammation, increases blood flow, and they heal much more quickly. Lucy's scars will likely fade in a year. If not, she can get laser treatments to help. Now, Dr. Earl wants fellow doctors to learn the value of hyperbaric oxygen. It's astonishing to me, the benefits of hyperbaric medicine. As a physician, I was not aware of the role of hyperbarics. We are not taught this in medical school. This is severely underutilized. Next, WWL, Louisiana. In medical cases like this, as well as diabetes, skin problems, insurance does pay for hyperbarics. Have you heard of other stories since our story aired of people who have lost some skin or something? Since our story has aired, as a physician, I have identified so many people in my own practice as a rheumatologist that I have sent for hyperbaric oxygen therapy. People that I would have never considered, and would never consider this form of therapy had this incident not happened to me. Because we're not taught about it, and it's generally not a widely supported form of treatment. And there are many reasons I believe that's the case. And Lucy, I see you smiling. You look really good. What do you think about everything you've been through? Everything you know looks beautiful. Was it scary when you went through all the treatments? Or no, it wasn't. Dr. Harch, there are cases where insurance doesn't pay. This is a major political, economic issue within the hyperbaric field. And the type of wounds that Lucy has falls into a category that is one of the reimbursed indications for hyperbaric oxygen. The problem is, we don't build direct insurance for various reasons. Often, many at Susan and with the help of plastic surgeons, myself, all of the information we get, they got reimbursed.
Okay, what's the purpose of that? Let's test my electronic abilities. The reason to show you that, it's not a brain injury. But if hyperbaric oxygen do this for a little girl's nose with no blood flow or oxygen, imagine what it can do for a child's brain with low blood flow and oxygen. And that's what I want to show you to finish this. Thank you to Robert, Will, and Beverly Boyton for this. Pause the last one. Pause that one. Okay.
Early in Robert's hospital stay, they told us that he was brain dead. They were poking him in the eye with a corner of a paper towel. They wanted his organs. And when we declined, then came a long list of matters. They even went so far as to tell us that everything that connected Robert was gone. They said he would never talk, he would never walk, and he would never run. Pizza! I don't get it. What happened here? I thought you were told you were gonna walk, talk, run, drink it. What's your name? How do you explain this? I'll have to let the audience decide. But very few medical professionals have used the theology to say this is not enough evidence that it works. Shows that by one doctor, and all wrong. In 2018, Will Boyton got a call that every parent fears. His youngest, Robert, at 3, drowned in a pond at a picnic. No heartbeat or oxygen for nearly an hour. Family and first responders resuscitated him, got him to a hospital near his home in Houston. First day, my wife called me and said, Robert had a pond. Tell me over the phone, we have to get him to the chamber. Will had read stories of brain damage being helped by Dr. Paul Harch and hyperbaric oxygen chambers. As an injured diver, he'd been treated himself. But for more than a month, he says 2 hospitals told him to let his son go and donate his organs. Reduction in blood flow and oxygen. The increase of oxygen during therapy helps carry that oxygen throughout the body, stimulating the release of growth factors. When Robert first went to Dr. Harch, his body leaning backwards. Injured area was living 8 inches at the back of his head. 2 days after his treatment, his bend was gone. Today, Robert is far from the original diagnosis of brain dead. You been down? After your knees on. There's so much animal literature and some humans showing that immediate treatment can have profound effects on even the severest brain injuries. It's important to note that even though Dr. Harch has been doing studies on animals back in the 80s and treating people with traumatic brain injuries, concussions, strokes, and drownings Since 1989, insurance still does not reimburse for this. He attended his stay in the hospital. He was successfully extubated that day after 36 hours leaving the trial. On top of this, parent success were approached by the head of the PICU and once again presented with the, you have to consider Robert's future, we can medicate him letting pass. We declined that. I fired the doctor at that point, told him not to come back in the room again, because at that point, you've been working with these doctors and you feel like you're on the same team, you're working for your child, and then you directly right out, you're going to punch in the gut. So there were two parts to it. One is this, you feel betrayed. I had a presence of mind to confront her, because now you've advocated that he's not Robert. We take him downstairs and put him in the chamber. Well, we can't do that. I said, why? What do you care? You just said we should ban him. He was taken upstairs and put him in the chamber. The response was that I hurt him. And that was already my flip comment of what they don't teach logic in medical school. Do you not catch conflict in what you're saying? "37 days out, and you saw it yourself. 2 hyperbaric treatments captured on video. There's no way to deny that the hyperbaric oxygen caused the awakening of this child and the straightening of him. Another treatment, and he was smiling. Can you imagine what would have happened if this had been done the day of his drowning? Here we are, 37 days afterwards, the brain started for oxygen, given a little bit of oxygen and pressure. What if he was given oxygen in the acute episode, when his brain was even more starved of oxygen, and he's comatose, profound effects? And guess what? There's precedent for it. This has been done in acute incapacitatus, acute severe traumatic brain injury, acute birth injury. There's a ton of evidence in animals. What has to be done? Comes down to reimbursement. But the good news is that we're at last going to have the opportunity to do this here in the United States. My senior partner, Keith Van Meter, for 40 years has been working on having a hyperbaric equipped ambulance. And now, this coming spring, in 2026, a hyperbaric ambulance will debut in New Orleans. So we'll be able to go out and get someone at the scene, acute trauma, acute cardiac arrest, you name it, put them in a chamber under pressure, resuscitate them, and bring them to the reimbursement side of it is very short. That's what we need to do. Because this is the undeniable evidence that this works for mild traumatic brain injury, persistent post-concussion syndrome, and cerebral palsy. But we can't get reimbursed. There is so much evidence now. There are 2 bills in Congress. There are already 14 states that have passed legislation to mandate hyperbaric treatment for veterans. But Congressman Murphy, Dr. Murphy, out of North Carolina has a bill in the House, and Senator Tuberville out of Alabama has a bill in the Senate. Both of them pass a law that's going to mandate the VA to start treating veterans with hyperbaric oxygen. We need your help too. We need massive support. Call your senator, call your congressman, and tell them to vote for this bill. And it'll be the first step towards getting this reimbursed for everyone.
We're not done. Here he is at his sister's wedding. We'll never walk, we'll never talk, we'll never... And what you don't know, he's in oversized shoes there that are the ones they could find for him. All right, hang on. Let's see how we do this. not computer savvy. So my goal in the rest of whatever's left in my career and life is to get this reimbursed. And that's what we're working on right now at the federal level. And I can't talk about it in much detail, but there's some very encouraging things that have happened, and hopefully next year, this conference, I hope to have good news. Thank you. So where's Rhonda? We due for a break is, yeah. One was hyperbaric air. One was hyperbaric oxygen at 1.5 to 1.75 atmospheres. And the third one was that control group where it was in one of the studies where they used 1.75 of oxygen or 1.5 of oxygen. Control group got the same pressurization, but they gave them a hypoxic mixture of air to breathe in the chamber at depth. So they gave them, I think it was 13.5% or 14% oxygen, which when you're under pressure, that translates to the equivalent of about 21%, or the same amount that we're breathing in air, not 21%, but anyways, the same amount. And what the study is just a disgrace because they terminated it earlier because they claimed that there was no difference between the two groups. Both had improved and had improved as much as, intensive physical therapy. But because this was this pseudo control group and they didn't understand hyperbaric medicine, they declared that it was a failure. And the article then written by one of the co-authors was an editorial in the Child Neurology Journal saying hyperbaric oxygen, the final nail in the coffin, which is we now have definitive proof that this is worthless. And so the point is they didn't use enough oxygen in that. Pressure alone had some effect. But no, that's not what we use. It's not what really anybody does. It's an experimental condition. Yeah. Do I refer out to providers? And the answer is no. And the reason is we've had so many problems with that. And this field, unfortunately, it is a formal subspecialty of emergency medicine and preventive medicine, but there's almost no regulation of it. A chamber is a prescription medical device and drug. When you're using 100% oxygen anyways, it has to be prescribed by a doctor, and it's supposed to be overseen as part of a medical practice. But what has happened is chambers have gone in everywhere. And many people, they're massage therapists. I'm not criticizing them. They're good at massage. But what are they doing using prescription device and drug? And so all I can just tell you is we've had a lot of problems trying to do that. And so what I tell people is, I'm in Louisiana. I'm in one place. I can't be everywhere. And we've tried to establish relationships with some, but it's hard to find people who want to do this as, I better be careful how I say this, but I want to do it as a practice type as a medical practice. And what I tell people is, if you have someplace, you go in there and you meet the doctor and talk to him and find out what their experience is and what they're doing, if he's even there. So many of these places are run by business people. There's no one there. Or you go in and you buy a package. I'll take 3 red lights, 4 cryos, and 5 hyperbarics for, $2,000 or whatever. And it's, there are more problems with this because you see what, I don't know if you're aware, in January there was a fire in a chamber in Michigan. A little 5-year-old boy burned to death. and his mother, trying to pull him out, got burned as well. And then in June, in Lake Havasu City, Arizona, a physical therapist operating a facility killed himself, burned himself to death in a chamber. And then in 2019 in Delray Beach, Florida, another place operated by a physical therapist killed a little drowned boy in a chamber. Yeah, you don't hear about this, and when people have bad outcomes, people they just kind of drift away because they either went there over their doctor's objection, they realized, well, there was no doctor there, this wasn't kind of a medical thing, and they take it upon themselves. So that little boy, the drowned boy in Florida who died in the chamber, the way we found out about it was on social media, where this got announced by the mother, and what the mother was saying was, I killed my baby. I was responsible. I went here. And what had happened was she had called up and was going to make some plans to come, and we were going to treat the child, and at the last minute did some local shopping and found this guy who said he worked with me. He was a business partner. They consult with me weekly, and mom ended up there. And it's just a horrendous story. It's on the internet. But the point is, we've had, I wish it was different. But just go into a place and you really, grill them, just like you'd be shopping for any medical care. So. Oh yeah, I'm sorry. I had no relationship with those people. I mean, I had known them from years before, but no, consulting with them, that was not what happened. Yeah. You got to speak up loud. Okay, that's a great question. So her child, 18 months old, has a shunt and a reservoir. And these are magnetic shunts, usually the way they are. As it turns, when people think about that, increase, what's that? Yeah, I know. They're called magnetic shunts is the basis of them. They're all pretty similar. Yeah, people think, increase in cranial pressure. And, you're putting them under pressure. No, it doesn't work that way. And in fact, all of those shunts are safe in a hyperbaric chamber. The company, if you call the company up that put the shunt, is responsible for the shunt that's in your child, what they'll do is refer you to a 2014 or 2011 article where a whole bunch of these shunts were tested formally under pressure, and they all function fine. So yeah, there's not a problem with that. We treated, oh my God, I'll bet 100 or more children with shunts, and it's not an issue. Yeah. Okay. I've treated people with 50-year-old brain injuries, and we've treated people at the end of life, people in their 90s with neurological problems. When we started all of this, that little CP kit in 92, we started in 89, going through to roughly 2000, 2001, I would not treat anybody who didn't have an injury that was a minimum of 1 year old. So we only treated, and all of this was based on treatment, but nothing but chronic cases. Why? We didn't have money to do a control group. So everybody had to service their own control. And you saw those curves. After generally 6 months, not necessarily, well, in kids, it can be a little longer depending on degree of injury, but 6 months to a year, used to be a year, people came to a plateau. So, we were out years on that. They aren't expected to improve. Now, if you improve, you really have done something. So no, the time, if you look at the CP studies that are done on the kids, they're between 2 and 13 years of age. And all of these were at birth or shortly thereafter. So no, ideally, if you can do it immediately, that's the best. And as soon and as close to the time of injury going out as you can. But by the time you're out, maybe 5 months or so, and I tell everybody this on the phone when we do, phone interviews with patients, that by that point, you're kind of in this more chronic phase, and it takes a chunk of treatment. Yeah. Oh, I'm sorry, I'm blind. But hold on. I have to quit. I got 5 minutes. Okay, be quick. Yes. Yes. Yeah. It's a wound. Doesn't matter that it occurred in utero. It still works. We've done this on many children. In fact, that's what they claim a lot of cerebral palsy is. I so disagree with it because the vast majority of the kids that I see with SCP diagnosis were not intrauterine strokes. It's a small percentage. Yes, I'm sorry. Say it again. You talked to my colleagues, what? Okay. So how do I dose this? Okay. Well, see, we started with a specific dose. For 10 years, everybody got the same dose. 5.5 years of it, it was a formal institutional review board approved protocol, an experiment, if you will. And we were trying to see, based on some information, that it was known that this dose seemed to be pretty good for patients with acute brain injury. What we found, though, yeah, it was pretty good, but there could be side effects to it. And in addition, there, some that didn't do as well. We had to have a lower dose. Well, that dose got known as the Harch protocol. And now that's what so many people, you go in the chamber and presto bango, you get that dose. But, your brain's different from mine. You put a brain injury on top of it, it is idiosyncratic squared, is what I like to say. It is extremely individual, and its responsiveness to any drug is going to be an individual phenomenon. We dose things by a range, but what I do is, with the children, because they're not cooperative, and I can't do what I do with the adults, adolescents, and cooperative older children, is I start at a dose and we'd look for it. It's a practice of medicine. It's like you have high blood pressure and you need to have a medicine. Let's say you do everything you need to do to drop your blood pressure and it's still high blood pressure. You stop drinking too much alcohol, you stop doing this and that, whatever. You still have high blood pressure, what do? It's a medicine. How many medicines are there? There are 100. There are some that are good for skinny white people on dialysis. There's some for older black people who are diabetic, people with kidney damage, et cetera, et cetera. So you pick one that kind of is good for you. And now what dose do you use? You have no idea. There's a dosing range the studies were done on, but that doesn't mean it's perfect for you. You pick a dose based on all of that stuff your doctor knows about you. And then what do? Goodbye and good luck? No. You come back next week and you check your blood pressure. And you ask, are you fainting? Are you dizzy? Are you having any symptoms and problems? And you dose people accordingly. And that's what I do with these children. We start and we look for an effect, and statistically at certain points you should see it. If I don't, then we have a discussion about changing dose. With the adults, we use quantitative EEG, and I put them in the chamber and go through a whole bunch of different doses, and we look at the brain live and the activity. And then I find out which one works best. Okay, we got to quit. Sorry.